be going. Now you can unmute randomly by yourself, right? Because wait, I've given you the rights. Yeah, you can randomly unmute by yourself. There'll be lots and lots of questions, but this
Infraglenoid.
so
Infraglenoid.
this session will be like a Viva. Just consider that I'm talking to you one-to-one. So even if someone has answered, you want to speak, go ahead. Okay?
Infraglenoid.
It is written also. यार तो सबको बोलना चाहिए, यहाँ पे लिखा ही हुआ था. हाँ, ठीक है. So very good. Right. This is my first lecture. Is it okay to continue? Absolutely, Girish. क्या problem है? Right. कोई बात नहीं. बिल्कुल. Do continue. And Girish, do take part in the Viva. Even I'll be asking you very simple questions, but it is important that you build that courage to speak, right? That would be very important. Shabash. Chalo. So this is the long head and this is the lateral head. What we are discussing, Girish, is the posterior part. Posterior means back, right? Back. So biceps aage, triceps piche, right? If you're going to gym, you know that thing very well. So, sorry. So this is the infraglenoid tubercle of scapula. Infraglenoid. Glenoid matlab it was the cavity. Kaun cavity on which the humerus will be connected, right? Because the humerus is, this is a shallow cavity. Why it is shallow? Randomly. Why it is shallow? Fast. Fatafat answer.
Mobility.
Shabash. Always give it like, because mobility is important. So what would be the name of this in the lower limb? What is the name of this?
Acetabulum.
Very good. Acetabular cavity. And that is deep. It is deep because there, what is important?
Stability.
Right, exactly. So in case of lower limb stability, in case of upper limb, this is shallow. So
Mobility.
that's what is possible in case if the glenoid cavity is shallow. So
Lower dislocation of shoulder.
lower dislocation. Why not any other side? Because of which?
Because it is not attached from lower side. The rotator cuff muscles.
Rotator cuff muscles. Rotator cuff muscle. Now you will not reply, right? Randomly. Pratik Patel. Rotator cuff muscles. Which four muscles? Fatafat. Samriddhi. I'll just wait for 2-3 seconds. Riya. हाँ जिनको पता है. विराज फटाफट यार बोलो. निशा. हाँ बोलो. रोटेटर कफ मसल्स कौन से? 4.
Supraspinatus, infraspinatus, teres minor, and subscapularis.
शाबाश. Right, that's how we write. Capital S, I, T and T को small कर दिया so that we don't make a mistake and we make it teres major गलती से ना हो जाए. That's why we will be writing. Sorry. We'll be writing it. S capital I capital T small and the S sits. These are the rotator cuff muscles which give strength to the shoulder joint. Because it is surrounding like this, inferiorly there is no support, so that's why dislocation of shoulder can occur in the, that is the inferior dislocation is common. All right, good. Moving on to this next one. This is the lateral head of triceps, right? Lateral head of triceps. Now see the importance of radial groove. Itna must importance. Radial groove is like this, right? Radial groove, because it is like a deep cut, must absolutely on the posterior side, in which those two royal components, they are passing. Radial nerve and the profunda brachii. Both are big. Above radial groove, below radial groove. Above radial groove, that is the upper part of the posterior surface, right? That is where, so it is the lateral head of triceps which is connected, attached. And below radial groove, what can we expect?
Medial head.
Medial head of triceps.
That's right, medial head. Now we are clear that where is it attached. This is the reason, big muscle connected above, and that's why we just cannot see. For that, we have to remove this muscle. Let's see that. Here it is, right? So here is, this is the medial head of triceps. This is below radial groove. How simple. Clear? Okay. Achha, by the way, what we are watching, which view is this? Which
Anterior.
Anterior.
because then and then we can, and which muscle is this?
Lateral.
Lateral
head of triceps.
That's right, lateral head of triceps. Because if we watch from posterior, we have to remove this muscle, then and then we can really watch this medial part. Shabash. Next. Now, rotator cuff, this we have discussed. So done. Triceps insertion, all three muscles, right? All three heads, they come down and they are superficial flattened tendon. Flattened tendon is called as aponeurosis. We learned that thing in the general anatomy. What is the importance of this aponeurosis? Why are we doing it like aponeurosis, right? Why it is like a flat tendon? Any advantage? Flat tendon. Strength, exactly. That is also written, right? Strength. Yes, it gives strength because that flat tendon is now focusing on one spot, right? And then that is what is called as the olecranon process. So all the fibers, right, they are coming, that flat fibers, they roll and then they connect at one point. So that's the reason that this becomes such a powerful muscle for which action? Wait, Shreya, randomly I'm asking. At least यार unmute तो कर दिया करो. Are there more Shreyas?
Yes, sir.
हाँ एक. हाँ Shreya, what is the function of triceps?
Sir, to build the weight, I mean, to transmit it, it actually transmits the weight to the middle
अरे
part.
simple. Biceps का function? Well, what are the two? This is arm. Two components, right? Two compartments. Anterior compartment, posterior compartment. Anterior compartment is called flexor. Posterior compartment is called
extensor.
So function of extension, right? Simple. Extension. बाकी तो all the muscles, मतलब ये वो नेता जैसा बात हो गई, right? Because all the muscles, they are used for transmission or transfer of the weight from one point to another point, right? So, next, this is medial head triceps, and that is what gives strength as it merges into that flattened tendon or the aponeurosis. Here comes our radial nerve. This radial nerve, which was posterior. Which view is this? Which view is this?
Posterior.
This is the
Posterior.
spine. Posterior. This is the spine which we are watching, right? Right from the beginning, we are palpating the spine of ours, right? Telling shabashi to ourselves. So this is the spine. So that means we are dealing with the posterior view. As we are dealing with the posterior view, this is the upper part. This portion. This is the upper part, right? It is the upper part because scapula is there. This is the part from where we can see that this radial nerve, right? It will be going down and it will be going into that radial groove. But before that, see these branches. See these branches. This one, right? Nerve supply, it is easiest to remember because whosoever is the nearest will supply. Mostly. Say, for example, long thoracic nerve, so it is like an exception, right? Because it has to travel all the way and then it goes for the serratus. But otherwise, if you want to bluff, right, and if you don't remember anything, so then the nerve which is nearest, it usually supplies, right? In most of the cases, it will be like that. So in anatomy, when we see that it is such a big nerve, radial nerve, when it is going into this posterior part, right? And these are the long and the lateral, right? This would be the long, and as it is going to that infraglenoid tubercle, and this is the lateral muscle, lateral head. So they will be supplied by the muscular branches of radial nerve, muscular nerve branches. Obviously, it has to be muscular, right? Because this is a mixed nerve. Mixed nerve means it is the muscular as well as it will be supplying to the skin. So that will be the cutaneous. That would be the sensory component. When we have got the sensory component, when we have got the motor component, it is called as a mixed nerve, right? So we are dealing with, means in style, when we say that it is the muscular branch of radial nerve, which will be supplying long and the lateral head of triceps, right? Here we have not done anything, but just we have done the show off, right? Obviously, it is the muscular branch. It will never be the sensory branch, correct? Right? But this is how it is. It is part of the posterior cord. Chalo, quickly. Who will tell me? Just randomly. Shravani. Medial cord. What happens? Fatafat. Medial cord. Bintu, yes. I saw you for the first time. Yes, go ahead. There is one root and then there is one nerve. Yes, which one? Go ahead.
Median nerve.
median nerve. So median nerve, right? It gives the medial root.
Ulnar also
Huh?
continue.
And the ulnar continues as the ulnar. Out of median root and lateral root, which root is bigger, Bintu?
Lateral.
Bhas gayi. Right? When we drew that, so if you remember in the, this is the medial
Ah,
column.
lateral. No.
No, median.
I'm confused.
Don't get confused. Just watch that figure again. You'll find that with yellow mark, right? We made the median nerve like this. That is from one is medial root, second is the lateral root, and we drew it like this, right? This means this median, that is the bigger component. Okay?
Okay, sir.
But see, now you are saved. In case Viva, if this question comes, so then you
Yes.
will survive. And you will never forget in your life. So this is done, muscular branch, long and lateral, all done. On to the next one. This is, now this is the elbow extensor, right? Elbow extensor. So this is the triceps, and we drew this thing in the beginning. This is the flexor component, and this is the extensor compartment of the arm when we take a cross section, right? So here, this is a muscle, so obviously it will be going for the extension. So this is the elbow extension because that's the free end. Now, clinically, when we'll be watching for certain conditions, all you need to do, this is the concept which we have already talked about, but still we are discussing it again, that there is always a tug of war, right? Flexor would try to flex, extensor will try to extend, but it is like when both of them, they are acting, so that's why this is in the center. Two things can happen. What if the wrist is dropped? That means these flexors are either they are working more. That is less common. What is more common? What if extensor, right? He was taking it back. Now extensors are not working. The flexors are working normally and it leads to wrist drop, right? So this is when this balancing component is gone, it leads to the final position of the organ, right? So this is what we'll be discussing. In order to understand this thing, here it is now. Let's take this. This is the radial nerve in axilla, right? All the way, brachial plexus, that is coming from the top. By the way, wait.
Sir, can I?
No. Acha, Khushmeen. Which nerve is this? The nerve marked. Just the name. No descriptions, nothing more, kuch nahi. Yeah. I'll wait for just 2-3 seconds.
So this the axillary
ये
no
खींच के मारा हो ना तो
axillary नहीं
axillary. This is axillary. Look, wait. Let me go on to the second page. The first page वाले ये सारे. हाँ, Zayed Sheikh. Which now? Surya. फटाफट यार, कम से कम अनम्यूट तो करो. Sachin in capital. चल. Which now? कुंजल. अरे यार, क्या मूड खराब करते हो?
समय.
नहीं.
Sir, may I?
नहीं.
Sir, may
नहीं. जो ये मे आई वाले ना सबको पता है इसलिए. नैना. Which nerve is this? Which nerve? Let me zoom. Okay. But you should be able to see it because it is so typical. मतलब नींद में भी पूछो तो पता चले. याशिका. स्वरा. क्या कर रहे हैं? Whether I should really conduct that Viva or not?
Axillary.
Dost, auxiliary.
Sir, I'm not sure, but can I answer?
हाँ बोलो.
Musculocutaneous.
It is. It is. It is musculocutaneous. मतलब ऐसी मस्त डाई मार के तो एक ही नर्व आ रही है ना.
Sir, axillary only till the lower edge of the teres major.
Exactly. 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 चलो कोई बात नहीं. But अच्छा है. Just start taking part. So this is the radial nerve, right? In axilla. Just make some dots are coming. Hello. Hello, hello, hello. Can you hear me?
Yes.
Yes, sir.
Yes, sir.
Okay. So here it is, right? The brachial plexus. By the way, which cord is this?
Lateral.
Lateral.
Lateral cord. Lateral.
This one.
Lateral.
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 Lateral. Yes, sir. Lateral.
Sorry. Now I can hear. Which cord is this?
Lateral.
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 Lateral cord. Okay. So you should be able to identify lateral cord, medial cord, posterior cord, correct? At least this much is expected. And which are the two major nerves associated with?
Axillary and
Radial and
radial.
axillary.
So you remember this part.
Yes.
Musculocutaneous nerve will emerge from lateral or
Lateral.
medial?
Lateral.
Okay. Now you can see. See,
Lateral.
lateral is with these two. That's the lateral, and here is the musculocutaneous. Right. So
Yes,
easy. All right. Good. Let this thing remain. Ha. Right. So here it is in the axilla. This is how the radial goes, and then in the axilla, from the axilla, now it goes posteriorly. As it goes posteriorly, right, it is associated with which artery?
Profunda.
Profunda.
And it will go into radial.
Radial.
Radial group.
That's right. Now here it is. We are just following, we are just tracing that radial nerve only. Again, this is the anterior view. All other nerves are seen, but we are interested in this. This is the level from where this radial nerve, which is posteriorly, but from this level, from posterior, it comes to anterior, right? It comes to anterior. When it is coming anterior, will it pierce something? Will it pass through something?
Yes.
Lateral
Lateral
intermuscular.
Intermuscular circle.
Very right. Lateral intermuscular septum, right? Because this whole arm is this is the humerus, very crudely drawn, but this is the lateral, this is the medial, and there is lateral intermuscular septum. Which muscular septum? Between the flexor component and the extensor component. So it pierces and will come out.
Sir, triangular
Triangular.
cross-section.
That's right. Triangular. That's why I said it drawn very crudely. Right? Yes, you are right. It should be like this. Okay. Then you will say, no, the muscular septum should also be like this. Okay.
Defined, well defined.
Well defined. So done. And at this point, right, over here, it would divide. right? We are tracing it right from the beginning. So here it is, as it is going down. Now this is AKA, also known as, it is also called as the musculospinal nerve. And I saw that thing, you wrote it in the chat box, musculospinal nerve, right? And it pierces lateral intermuscular septum. We talked about it. And let's move further. Now this is the posterior component, posterior part. This is the posterior part where we see it in radial groove. And that's what it is associated whenever there is fracture of shaft of humerus. When the shaft of humerus is damaged, this nerve is likely to be damaged. Likely to be damaged because now it is engraved as if it is engraved into the bone. So when bone breaks, it takes the nerve along with it. So this is the zoom portion, is the anterior view. Here it is the axillary or the axillary and option, right, slash brachial. Wait. New name, Rutvi, Hrutwi. At what level the name would change from axillary to brachial? At what level the name would change?
Sir, may
Sushmita?
I?
No. Sushmita?
Sir, may I?
Sir, may I?
Sir, may
Okay.
I?
हाँ चलो
Sir,
बोलो.
may I?
Sir, may I?
Sir, may I?
Wait, because all of you are on first page, right? So Shiva, go ahead.
After first trip.
After first trip, यार अच्छा है, we are not studying offline. जो फर्स्ट ट्रिप यहाँ पे, फर्स्ट ट्रिप यहाँ पे, मैं तो सही में मैं तो लगा देता यार. फर्स्ट ट्रिप यहाँ पे, नोबेल प्राइज ऑफ एनाटॉमी गोज टू यू.
Sir, can I?
हाँ सुधांशु चल बोल.
After passing through the teres major muscle.
हाँ एग्जैक्टली राइट. तो ये फर्स्ट ट्रिप में क्या था? चलो, हु विल टेल मी व्हाट वाज दैट? दैट इज द आउटर बॉर्डर ऑफ फर्स्ट ट्रिप.
Axillary.
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 Then after that, axillary.
Exactly. So from subclavian, then right, it is a continuation, then it changes.
Axillary.
Axillary.
To axillary, and then axillary to brachial, and that
Brachial.
brachial, it goes down, and then it divides, right? And then we see it further. Okay. But see, this is what really happens. अच्छा शिवा, बुरा मत मानना, right? मतलब समझ लेना कि मैंने आपको एक लगा दिया. But you'll remember it. You'll remember it. Right? It happens. That's what I said. See, this is like a home ground. अगर जो वहां पे एग्जाम में ऐसा बोल दिया फर्स्ट ट्रिप, right? तो they'll take out their Colt revolver और 6 की 6 गोलियां पॉइंट ब्लैंक में मार देंगे. Because it is like, now you can understand, right? It is like such a big crime. So this is a home ground. मतलब मैं कुछ भी बोलूं, don't feel bad, but it is important. Okay? Now you will never forget in your life.
Yes.
So done, right? This is, so we have got the axillary artery, that brachial artery, which is always in front. Brachial artery will be coming in front, right? आगे आ गई. This brachial artery will be traveling all the way down, but it gives one branch which goes posteriorly. Which branch?
Profunda brachii.
Profunda
Ash?
brachii.
Deep brachial artery.
Yes. So
Or
that
deep
profunda.
brachial artery.
Yes. So that profunda brachii, along with the radial nerve, now they are traveling posteriorly. Good. Here it is. This is the radial nerve, which is into the radial groove. You can see straight away it is going into the radial groove. Let's move further. Now here it is. the deltoid tuberosity which we were talking about, right? Deltoid tuberosity, because all the way that big deltoid which is coming and then it is landing on the lateral surface of the humerus, right? So that's why. How many components are there of deltoid? Tanish. गिन चुन के ना कुछ ही नाम आते हैं. Acha, Kunjal, yes, I asked you one question and you didn't reply. Yes, Kunjal.
Yes, 3 components.
Which 3?
The medial, the lateral.
Median. Those again, एक Nobel Prize देना है आपको for the median fibers. कहाँ मतलब कहाँ घुसाओगे यार median fibers deltoid के? Deltoid, we said that it gives that curvature to the shoulder. इसमें median fibers was कहाँ से लेके आए? Think it. Which 3 components?
Can I say, sir?
हाँ बोलो.
May I?
Anterior, lateral, and posterior.
Anterior, lateral, and posterior. That's right. Right. इसीलिए तो then this group of fibers, this is the humerus on the lateral side, right? They were getting inserted such a big muscle, so many fibers, and anything, Preeta, what are the type of fibers which are these type of fibers?
Multipinnate.
Very shabash, right? See the creativity, very shabash, right? दोनों को mix किए. So that is the deltoid tuberosity. It is one of the important landmark. Deltoid tuberosity, and
which is the fiber? I don't remember.
Yes.
Which fiber?
Multipinnate fibers. Right? In multipinnate, what really happens starts with 4, ends with 3. So they are like this. These are called as the multipinnate. So this gives, they are called as the multipinnate fibers. Basic function, it focuses the strength at one point. That's the reason when it is inserted in the deltoid tuberosity, it will generate so much of power that it will create a tuberosity, right? It will create a tuberosity, a big rough area which can be felt easily. So that is the deltoid tuberosity. The lateral intermuscular septum, it is pierced just at the distance of 2 inches or 5 centimeters below the deltoid tuberosity. Why we are learning this much? Because when we'll see the fracture and we'll see that this fracture has occurred at which level, this is to make a judgment that which nerve can be damaged. So just from the X-ray, so many things can really be said. So this is the point, that it is this lateral intermuscular septum. Our radial nerve, it will be piercing it and it will be coming out. It will be piercing it and it will be coming out at this level, which is 2 inches below the deltoid tuberosity, right? It's below the deltoid tuberosity. So here it is. This is the anterior view. So now what we are watching is, say this is the, right, just from this, we can see this is the lateral view and here is the radial nerve which is coming, right? That's the radial nerve. And this we just can't miss, right? This is the brachial artery, big artery, which is anterior. So just from this, we can see that this is the anterior view, correct? We are watching the anterior view. We are watching the cubital fossa. And this is the brachial artery, which is coming. And now it will divide. Okay? Brachial artery is coming, the nerve which is associated with it. You know that? It is the
Median
nerve.
And this is the one behind, right? This is the ulnar nerve, which we used to say funny. अरे यार लगे तब पता चले मतलब क्या current लगता है, right? So that is not at all funny. It is painful, but they say that it is a funny nerve, right? With which disease this nerve is associated, because when we palpate, it becomes like
Leprosy.
Right. In case of leprosy, this becomes like a cord, so that you just touch it, right? And you feel like that it is like a thick rassi. But don't do much, because otherwise patient will hit you. It is that painful, right? Here it is the musculocutaneous, right? Musculocutaneous, which is the anteriorly situated. So yes, just from the layout, this is like a picture. This is like a visual impression. Just by watching, you know that on the lateral side and on the medial side, what we are getting, right? And as such, on the radial side, there is radius, right? Bone. So this is the radial nerve, easy to remember. So similarly, ulnar nerve, that is also easy to remember. Median, name itself is telling that it is on the medial side. So that is also easy, right? So we know we cannot say make confusion between radial nerve. This is the ulnar nerve, that is also clear. Then median nerve, that is also clear. Ulnar nerve, so we have felt that yes, it is so painful on the backside because kahin pe wo kursi pe bhi aise lag jaye, kahin lag jaye, to we get jhan haath mein. That's the radial nerve. So you know, that thing is no confusion. Bas done. Bas, all nerves so you have identified. So we continue. So coming back to this, the radial nerve, which is on the lateral side, as it is coming near. So we say that radial nerve as it crosses the lateral epicondyle. Wow, kya style, right? Lateral epicondyle, obviously it will be there only. And this is the lateral epicondyle and this is the medial epicondyle. Or ho hi kya sakta hai? There are no other bones, right? So it is the lateral epicondyle. Radial nerve over here, it gives two important branches. One is the deep branch and second is the superficial branch, right? Deep branch, bas wahin pe branches dekhe, it ends over there. Its life ends over here. It is the superficial branch which would continue further, right? So this is a small piece. And by the way, this beautiful brachial artery, right? Now it is dividing into 2, 1 and 2. No big rocket science. Radial side, radial branch. This is the ulnar branch. Radial as it will be going all the way up to the wrist. Yes, at wrist, we can take the pulse because why do we get the radial pulse and not the ulnar pulse?
Because
Reason?
it is on the hard surface.
It is on the bone.
It is on the hard surface because the radial bone, it is flat at that point and the artery is lying just above it. So when we use 3 fingers, our central finger will be feeling the pulse. First finger will be applying the pressure. And this third finger, it will be adjusting the pressure in such a way so that the middle finger, it gets the best bounce, right? So that for that, a hard surface is needed. Ulnar pulse can be taken, yes, but when you try to take the pulse, right, that artery itself, it sinks down, so we don't appreciate the pulse properly, right? So that's the radial pulse. Let's move further. Here it is. This is the posterior component. This time we are doing darshan of both the things together. That is our radial nerve and the profunda brachii artery. Both the things they are seen together. So we have got, this is the brachial artery, right? And as it gives one branch, this brachial artery will be moving forward. That is the anteriorly and posteriorly. So this is a posterior view, right? This is a posterior view, though not written, but we know that, right? That this is the posterior view. Profunda brachii, radial nerve, they are passing into the shaft, into that radial groove. And they go down. So here, acha, let's ask this question. You remember we talked about.
Yes.
Remember this? Yes. And that was even the audio which you were supposed to record and send it across.
Yes,
And I
sir.
said that you have to do it without watching. You have to remember it. Now, if you have really done it, you'll find that it is so easy to remember what it is. Correct? That was the importance, that when you speak, it will be imprinted into your brain. So here the question is that this radial nerve and the profunda brachii, they come out of which space? Now we were talking about 3 spaces, right? One, what was the name of what was the name of this space?
Quadrangular.
Triangular.
What was the name of this space?
Upper triangular.
Triangular.
Yes, triangular. And what was about this?
Triceps.
Triangular.
Very true. And it was made up with the borders, right? This was the triceps, the long head of triceps, right? on the medial aspect. Then on the lateral aspect, you are having humerus and the
Humerus.
lateral head of triceps. And the roof was made by the lower edge of the
Teres major.
major. Very right. So that is how you'll be replying, right? So this is the space through which it will be traversing or it will be traveling. In Viva, examiner can ask you about any of these spaces and you have to describe that space, right? And I know you can do that. Here is a very simple layout of radial nerve distribution. As the radial nerve starts above, right? See, here it is written radial groove. So that means we are dealing with quite a higher level. This is the posterior cutaneous nerve of arm. Posterior cutaneous nerve of arm. Cutaneous nerve, that means this would be the sensory nerve. Correct. This will be the sensory component. So it is giving to posterior cutaneous nerve of arm. Then it is giving branches. Branches to whom? We saw that it will be supplying to long head of triceps and the medial head of triceps. Okay. It comes down. It comes down and it will be supplying to lateral head of triceps. All right. This is done. This is done. This is done. But then in the radial groove, there is one more branch which will be going up and it will be supplying the medial head of triceps. So that means triceps it has got the dual supply. It has got the dual supply. So when it is said that if radial nerve is injured above the radial groove, which head of the triceps is spared?
Medial head of the tricep.
Medial head and the long head, both.
Medial and long both.
Medial and
both.
long, both. The head affected would be lateral head. Because medial head got the dual supplies, right? It is also supplied from here and supplied from here. All right. Coming down, this will be having posterior cutaneous nerve of forearm. This is important, right? This is posterior cutaneous nerve of arm and forearm. They both are getting supplied. And as it comes down, it is also the lower lateral cutaneous nerve of arm, right? So that is also coming up. This is a muscle. Enconius. You'll see this muscle, but this muscle is also supplied by this particular nerve. Now here are the branches, right? It's a continuation, right? So that now we have crossed the cubital fossa and now we are going down. We are coming down, right? As we come down, see we have got brachioradial. We have got the brachialis, right? We have got the brachialis. We have got the, by the way, what is the nerve supply of brachialis? Nerve supply of brachialis. क्या बड़ी-बड़ी बातें की थी यार?
Musculocutaneous.
Musculocutaneous supplies which three muscles? One तो बोल दिया आपने brachialis. Correct. Right? All those BBBs, right? So biceps brachii, coracobrachialis, and the brachialis, right? These are all supplied by musculocutaneous nerve. It pierces which muscle? Coracobrachialis. So we'll put a star, right? This is what we are doing, right? Why to remember? Just you do this and it will automatically come in your mind. Musculocutaneous. The thing is, now this is a tricky part. Actually, for the nerve supply, for the brachialis, it is the pure motor which is supplied by the musculocutaneous nerve. Right? Motor fibers to the brachialis. But then it is the radial which is coming and it also sends some of the fibers to brachialis, and these fibers are very specific. These are called as the proprioceptive fibers. So proprioceptive is what? That even if you close your eyes and you put your hand like this, so then you can say that yes, my hand is like this. So this is like 3D orientation of the movement and the position of that particular organ or the muscle or the joint. That is what is called as the proprioceptive sensations. So this is very specific. That is for the brachialis. Proprioceptives, they are coming via radial, right? And the motor fibers, they are coming via the musculocutaneous. Right? Then comes the brachioradialis, and this is the ECRL. These were called as the carpals, correct? Carpals. Right? So they are collectively called as the carpi. Extensor carpi radialis longus. So these carpals, right, they are for the movement. This is for flexion, this is for extension, right? So this particular muscle, which will be obviously onto the extensor side, that is on the posterior side, it will contract and it will make these carpals extend. So extensor carpi, right? It is on the radial side, so extensor carpi radialis, and it is a long muscle. So that means there will be another short muscle also. Short is called as the brevis. So we can expect that there will be someone called ECRB, extensor carpi radialis brevis, right? Yes, it must be there, right? So this is ECRL. Right? So thus it divides into superficial and the deep branch. Now it has given branches to all these muscular branches to brachialis, brachioradialis, ECRL, extensor carpi radialis longus, goes still down, right? Goes down, and then it divides into superficial and deep. And in superficial and deep, right? This superficial, right? Which is long, it gives to cutaneous branch. It gives all those cutaneous branches. So it means it is sensory. What about the deep? Deep is busy in giving supply to all those muscles. So here is ECRB, what we were expecting, right? This is extensor carpi radialis brevis, right? This is extensor carpi radialis brevis. Then there is supinator and the muscles of back of forearm. All these muscles we'll study next time when we'll be dealing with the forearm, right? You'll be able to remember all of them. But this is how it is going. Say radialis has taken over all the posterior components, right from the top. Still it has reached to the forearm. Still it is busy, right? So much so it goes down, and here it comes the hand. In hand, this is the palmar surface, this is the dorsal surface. So it comes to the dorsum. It comes to the dorsum. In dorsum, it supplies lateral 1.5. So in anatomical position, lateral 1.5, that means it is this area, right? It is this area which is giving sensation. And by the time when we reach over here, we feel like, kyun itni sari details, right? And not only that, we are talking about that hand, it is this dorsum. And when it comes to digits means these fingers. So lateral 2/3. So 1, 2, and third digit, matlab itna adha. And that also there is something more written, right? Except terminal portion. That means not this, not this. What's all this? See, so simple. If the radial nerve is damaged, so that means these sensations will be lost. So test kahan pe karoge? Right? So when you take the hand, radial side, so just this much, itni patti, right? Sensations will be gone over here. Take the digits, right? यहाँ पे कुछ पता नहीं चल रहा है, यहाँ पे नहीं पता चल रहा. The moment you touch over here, patient will say, "हाँ, I can feel that," because these terminal portions, they are not biradial, so it is only this back portion. यहाँ पे this strip, right? So how to define? We just cannot say कि वो इतना area, right? As we said, that whenever you write any of the report, it should be so specific that even if person closes his eye, he should be able to visualize. So that's why when we say dorsum of the hand, we know that we are talking about this part, right? It is this 1.5 digits, so it means it is this much portion. Yes, that means. When we talk about digits, these are called as the digits. So 2.5 digit, ek, do, and this is the adha digit, right? So this much is supplied by radial, not the terminals, except terminal portion. So this terminal portion, not these, right? So very clear. If we really draw it, right? If we really draw it, right? This much is this is the dorsum. Dorsum, right? When it comes to hand. When it comes to digits, right? This much. So this is 1, this is 2, and this is 3. So 2.5, right? So this is 2.5 digits. But this tip they are okay, right? So that is how. Lateral half, lateral half. Right? So this is the medial half, this is the lateral half. अच्छा 1.5 ऐसे, हाँ. This is lateral and medial, मतलब हाथ में तो ऐसा है ना, तो lateral and medial. Got it. So this is how it would really go. So digits lateral to third except terminal portion. Do remember this, right? Except terminal portion. So sensory and the motor, and sensory to hand and the lateral 2.5. So this profunda brachii, which is also called as the deep brachial artery, that is also passing along with it. Now we are focusing only on the artery, right? Only on the artery. We have removed the nerve just for the sake of simplicity, right? Just for the understanding. So here it is going into that radial groove, we call also known as the deep brachial artery. At the deltoid tuberosity, right? It gives one branch, and this branch is called as the middle collateral artery, right? Middle collateral artery. But interestingly, the most important artery which is going on, and that one is this. As it goes down, this is the radial collateral artery. Whenever we say radial collateral artery, understand that it is for collateral circulation. Collateral circulation means it is for the anastomosis. Correct? Anastomosis is nothing but it is like a bypass. It is a backup path. And in this anastomosis, one who is coming from the top, it will be called as the collateral. One who will be coming from below, it will be called as recurrent, right? Collateral means with the flow, recurrent means against the flow. So we have got the radial collateral artery, which is over here, and it should anastomose. It should anastomose with one another artery which will be coming from below, and that is the radial recurrent artery. Recurrent, right? Name is clear, recurrent, and then they both unite. On to the next one. And this one is the middle collateral artery, and this middle collateral artery, this is from the top, and it is the longest terminal branch. And because this is the area where our medial head of triceps, that shy muscle, right? That shy muscle, it was lying over here. This middle collateral artery, it passes through the belly of medial head of triceps, right? This is the middle collateral artery. Because it has got no other option. Muscle is attached to it. It will say, I have to pass through you. And it passes. And then there is one another. Again, see, recurrent. That means it will be going up. Interosseous artery. Very truly, the name given, very honestly, it is between those two bones. So that's why it is interosseous. So it is the recurrent interosseous. Bus, that's it. You have completed. It is a recurrent interosseous. You have to remember middle collateral artery, radial collateral artery, and the recurrent artery. That is what makes the anastomosis around the elbow joint. Okay. Back. We are over here. This is the long head and the lateral head of triceps. And we said that it is the profunda brachii, right, with the branch of this brachialis, to deltoid tuberosity, and it goes. And then there is this associated one. This is the posterior circumflex humeral artery, which will be going over there. But the point is, that was the thing, that which artery is this, which is at the surgical neck, right? It is this posterior circumflex humeral artery at surgical neck. Humerus. Which other structure you will find at surgical neck of humerus? Along with this
Axillary nerve.
axillary nerve. Axillary nerve is a branch of which cord?
Posterior.
Posterior. Okay. Now comes the radial nerve compression. Now the clinical part. From this point onwards, everything is clinical. You will see some of the very interesting cases also. This is radial nerve compression. Radial nerve, when it is compressed, right? Obviously, it will be affecting all those muscles which are supplied by it. At the same time, it will also affect the sensations, right? So first, which is also called as the crutch palsy. Crutch palsy. Crutch means those who are unable to, unfortunately, those who are unable to walk, right? So they need to use this crutch, Baisakhi, right? Now it generates tremendous pressure into the axilla, and that is the point when the radial is actually going, right? So radial gets compressed. So that is what is called as the crutch palsy. Also, right, it is also called as the honeymoon palsy. Now, after that session, right, when the female is, say, her head is onto the shoulder, right? Right? When her head is onto this axillary region, so there is constant pressure of that head. So next morning when the guy wakes up, right, he finds that yes, there is loss of sensation and hand is not working properly. Nothing happens, right? It recovers within a day or two. But this is because of the compression, constant compression. It is what is called as the radial nerve palsy. Interestingly, this is also like Saturday night palsy. Right? Well, depends. But yes, it occurs more in case of males as compared to females. But the point is, right, whatever the way we remember, the point is it is the constant prolonged compression. That is the key culprit behind this. Constant prolonged compression. Now, what would happen in this case? So radial nerve supplies. It supplies triceps, yes. It supplies anconeus, okay. It supplies brachialis, yes. It supplies brachioradialis. It supplies extensor carpi radialis longus, right? All these are supplied. We start with first one. What is called as the wrist drop? Because when anything happens to radius, right? Wrist drop is very common, especially when the person wakes up, right? He finds this most commonly affected. Wrist drop. It is because the function of ECR, extensor carpi radialis longus, right? A long muscle is pulling the wrist back. Now that muscle has gone, the wrist has dropped, right? So this is because of ECRL, extensor carpi radialis longus. Do you remember? Yeah, we talked about this. Brachialis, it is bimuscular. It is also called as the Caserio nerve. Caserio. No, this won't be asked in exam unless and until you do so good, and that I won't be having any option but to trick you, right? So then I'll say that, okay, Caserio nerve supplies which muscle. But now I have disclosed that also. Anyway, right? And in 80% of the cases, that is in mostly, this is the radial nerve. That is what we talked about, C5T1. This is angiography, right? In angiography, normally you don't see the nerves. When you take normal simple plain X-ray, you don't see the nerves because the density of the nerve, density of the axilla, and density of the nerve, density of the artery, density of the veins, density of the muscles, they are all collectively called as soft tissue density, right? They are called as the soft tissue density. Unless and until there is difference in the density, you won't be able to see that structure crisply. Bone density is totally different. Metal density is the strongest. That's why when someone has taken the X-ray chest and if there is ek rupaye ka sikka in the pocket, then you'll be watching it very clearly. You won't be saying that this is space occupying lesion seen in the upper part of the chest. No, because it is metal density. Metal density is sharply, clearly focused, right? Very well defined. So you'll be able to identify between the bone and the sikka, right? Ek rupaye ka sikka very clearly because bone density is slightly less than the metal density. But when it comes to soft tissue density, sab ek jaise hi hai. Now, if you go to CT scan, now in CT scan, you have got the panel, right, on which you can control those windows. So you can clearly differentiate between various types of soft tissues. When it comes to MRI, the MRI is a completely different ball game, right? T1 weighted, T2 weighted, as we discussed, that it depends upon the amount of water which is got, right? So if the water content is more, so it will in T2 it will be giving a bright image, and T1 it will be the dark image. Kyun? Because we remember that Mumbai principle, right? Jamin, land heats up faster, cools down faster. Water heats up slower, cools down slower, right? So who will be the emitting the energy? So whether it is in T1 weighted or it is into the T2 weighted, and accordingly you take a call, right? So over here, we do angiography when we really want to see the vessels. Now over here, we want to see the artery. Now in this artery, the dye which is injected, that dye is a radio opaque dye. It is called as the radio opaque. Radio opaque simply means that X-rays won't be able to pass through those dye. So if the X-rays cannot pass, so that means that structure will be appearing white, correct? Barium sulfate, that is which is used for the digestive system, right? So barium is for that. So it is, whether it is the barium swallow, barium meal, even barium enema, right?
Then what is for this angiography? Which
This
dye
is,
will we use?
there are dyes called venographine, angiographine, right? These are all iodine-based dyes. In general,
Okay,
you can
iodine
say
based.
iodine.
Okay, the iodine 321, iodine 1231s, and
Yes,
those ones.
based dyes, right?
Isotopes one.
Yes, isotopes. So that is what is used. So over here, what we really watching is that as the dye was injected, see this large area, right? The area, large area is seen. So this is seen on the angiography. This is what is called as the aneurysm. Aneurysm. Aneurysm means the walls are thinned out, right? So this is like, this patient is like a ticking time bomb. When, if it bursts, because it is the in direct continuation with the aorta, right? So if this thing bursts, this thing breaks, so then the game is over, right? There is nothing what can really be done. So over here, because the amount of blood which is pumped out, it is at the rate of 5 liters per minute. More than 20% of the blood loss, that means more than 1 liter of blood loss, if it is there, then the person dies. So in such cases, right, these are some of the cases which are of importance. From this patient is like a ticking time bomb. Should be going for surgery. Achha. So over here, this is what is called as the aneurysm, axillary artery aneurysm. It is bulging of the arteries, walls are weakened. Let's watch something more. So this is the aneurysm site. This is the complete course. Here is the artery which is supplying oxygen, and the muscle is happy. One day, anything goes wrong to the artery, injured, so no oxygen. No oxygen, so that this muscle is not getting blood supply. It is called as the ischemia. Right. Still kuch nahi, that area starts going into the state of necrosis. Sarne lagta hai. Next stage, fibrosis. It is irreversible. So this whole thing, so when the fibrosis occurs, that thing, it starts getting contracted. And in that state, you can see the difference between both the hands. This is normal. See this. It is what is called as the Walkman's ischemic contracture. Walkman's ischemic contracture. See in this case, brachial artery would be damaged. Right. Let's see this. Sorry, repeat. Here is the brachial artery as it is coming from the top. This is the supracondylar fracture. So the fracture is occurring just above the condyle, and this is the commonest site from where the brachial artery can be damaged. If it is not taken proper care of, then obviously it will lead to major complications, what we saw above. So supracondylar fracture. Another thing, We talked about Orb's point, right? When we discussed brachial plexus, we talked about Orb's point. This is the Orb's point, the point where 6 nerves meet. So one is the root of C5, root of C6. Then there is the anterior and the posterior divisions. This is the upper cord, upper trunk, right? And then we have got nerve to supraspinatus, and we have got the nerve to subclavius.
The suprascapular.
Suprascapular, spinatus, suprascapular, right? Suprascapular. So, so we have got the 6 nerves over there. Now, when the damage occurs, these are the, so this is the suprascapular nerve damaged, chance, and it will affect the axillary, it will affect the musculocutaneous, because this component, as it will go, right? You must have noted that as it will go, right, these are the nerves which are affected. Now, when this position is important, though it is written, it is in a very, say, derogatory fashion, it is also said as policeman tip hand, right? Policeman's tip hand. In many of the books you will find. So policeman tip hand or porter's tip hand or waiter's tip hand, that is the hand goes like this. We just see that why the hand really goes like that. So first thing first, muscles affected, we need to see right from the beginning, the deltoid, right? Deltoid is affected. The function of deltoid is abduction, right? When it contracts, it is the abduction. But now that muscle is not working. So pectoralis major will take over and it will pull the shoulder near. So this is what is called as the adduction. So muscle affected, and this is the abnormality which patient will be getting. So we'll keep on doing it along with it so that we remember that what we are doing. So this is, it will lead to adduction. So done, adduction is part. Then supraspinatus and infraspinatus, right? They are affected. So supraspinatus, infraspinatus, they were going for the external rotation, right? Because contracting from above, they are not working. So internal rotators will take over. So now the position of the hand is adduction, internally rotated. These two done. Biceps, right? So if now the biceps flexes, biceps is not working. So then the triceps will come into picture. So hand, so now this arm is extended. So this is 0.1, right? It is adduction. This is 2, internal rotation. And from the elbow, it is extended. So even if we do this much, right? Parallelly, if you are doing this much, so you'll be able to feel, yes, this is. Then comes the supinator. Name itself is telling supination. Supinator is not working. The hand will rotate, right? So this is the pronator. So this is the 4th one. It is the pronator. And then finally, this is the wrist drop, right? And we saw that extensor carpi radialis longus, right, which was keeping the wrist straight. Now it is paralyzed. So this drop. Combine all the 5 movements, right? So this is adduction, internal rotation, extend the elbow, right? Extend the elbow, and then put it into the pronation, right? That is like this, and then bend the wrist. The shape which you, or the posture which you have got is waiter's tip hand or the porter's tip hand. What really happens at the Erb's point, correct? Erb's point. So this is the final position or the final abnormality. Yeah. Now this thing is usually, if you answer this much, it is more than enough. But there is something extra. As we drew that C5, C6, C7, C8, T1, right? This is how we went. So this will be the 4. So nerve is going. This C4, C5, right? This is not part of the brachial plexus. Brachial plexus was C5, C6, C7, C8, T1. But this one, yes, C5 involvement is there now, right? So this C4 C5, it leads to the nerve what is called as the phrenic nerve. So during injury, if the C4, C5 root is also damaged, right? So then the diaphragm is affected, right? So that leads to elevation of the diaphragm, right? In order to contract, it has to pull, right? So that it remains tight. When weak, it will be going like a dome, right? It will go up. So this is what is called as the diaphragm elevation. So in Erb's palsy, when you say this thing, so this is that extra point. Over here, right, if it is a shaft of humerus, right, you can see that there is extensive fracture of the shaft of humerus. Which nerve would be damaged? Radial nerve. Radial nerve damage. Okay. When we'll be discussing the hand, at that point, we'll be discussing all these signs again. Right? These are all classical clinical signs. Within seconds, you just check whether the rest of the nerves are normal or not. This is what is called as the peace sign. Peace sign. So you make a V, right? So this is to check ulnar. So we write it like this. It is vulnar, right? U can be written like this. Right? These are all shortcuts so that we don't miss. Initially तो सब याद रहेगा, but when anatomy, physiology, patho, pharmac, तब ये याद आना मुश्किल होगा. But the moment we say that ulnar, so this is like V, so we used to say vulnar, so pakka, this is ulnar only. And then the confidence rises. You know, this is because of this only, right? Nothing else. It is called as the peace sign, Shanti. Right. Then the next one. This is the radial nerve, right? Radial nerve. याद किस तरह से रखा? Radial side, thumb up, right? This is the radial side. So bus 100%. This is what is called as the hitchhiker sign or thumbs up sign. So सबको यूं, right? All the best, all the best. So my radial nerve is working fine, right? This is done. And finally, the median nerve, right? Power to people. It is called as the power to people, right? Jindabad, Jindabad. Yes, what you sent, right? Jindabad, Jindabad. So that is the power to people. Yaad nahi rehta, right? So isliye what we did is median is like union, right? Union baji, right? So that is median is union. So now we know that this union, right? That is median now. So it used to happen like that when we many times when we used to go to that Golden Qatar. Golden Qatar was the name of the theater of Indian Army, right? So we used to go for movies over there. So in movie, when something like this used to come, we say, dekha kaun si now, right? This is the union now. Union now nahi, matlab median now. So median nerve is there. So median nerve is there, but there is one branch, right? If you want to be very specific, right? If you want to really be very specific, that the anterior interosseous nerve to damage nahi hai. So this jai ho, right? That is the median nerve. And which sign will you be doing to check anterior interosseous nerve? So you'll say, yeah, kya baat hai, right? Exactly. So this is called as the okay sign. So when you say this, right, they say ba, right? And that is the anterior interosseous nerve is fine. So this is to test specifically, right? This sub cheezein, when we'll go to clinics, right, it will be like, you'll love it, right? Matlab patient will also feel ki, chalo aisa karo, right? And when we'll be discussing about how to take the history, we'll find that when patient tells do it like this, you just put a finger and then try to take the finger out. If the muscles are weak, right, your finger will smoothly come out. Do it on the opposite side and you will know that yes, there is imbalance. Correct. So that's it. Done for today, right? So that was for today. Next time, we'll be taking the forearm, right? So in forearm, I just tell you in advance, this would be our pattern. We'll be taking forearm 1. That is in forearm 1, we'll be taking the flexor component of the forearm. Then we'll take hand, right? Not this extensile component. Then we'll take the hand because it will be coming in a one single rhythm. And then the third session will be with the forearm part 2 plus hand part 2. So this is where we'll combine everything. And then we'll have one session on pure clinics. That is where we'll be watching X-rays, CT scan, MRI, angios, everything, right? One full session. But so this is what we'll discuss on Saturday. This will be on Tuesday. This will be on Thursday. So Saturday for clinics. देखेंगे. So we might have to postpone the exam by one day. ठीक है, देखते हैं. So we'll see. But this is how we shall proceed. Okay. So yes, this all great. I know your ulnar nerves are good, median nerves are good, interosseous is absolutely fine. All great. Thank you so much. Love you. Bye-bye.
Thank you, sir.
Bye, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir. Bye, sir.
Bye.